Hello, everyone. Today, I will be presenting a phase-specific cardiac rehabilitation program designed for Adam Swartz, a 62-year-old male recovering from an ST elevation myocardial infarction or a STEMI, who subsequently underwent coronary artery bypass graft surgery involving three vessels through a median sternotomy. This presentation will cover exercise prescription across all three phases of cardiac rehabilitation, including inpatient rehabilitation, outpatient rehabilitation, and long-term maintenance. I will also discuss special considerations for patients with chronic heart failure, along with safety monitoring, exercise modification, and clinical decision-making throughout the rehabilitation process. So our patient is currently post-operative day 2 following CABG surgery. Several factors influence his rehabilitation plan. First, he is deconditioned due to the surgery and prolonged bed rest. Second, he reports incisional pain rated 6 out of 10 during movement. Third, he is anxious about physical activity and fears overexertion. Additionally, he is taking a beta blocker, statin, ACE inhibitor, and antiplatelet medication. The beta blocker is especially important because it blunts the normal heart rate response to exercise. Because of this, heart rate alone is not an ideal method for determining exercise intensity, but instead we will rely heavily on ratings of perceived exertion and symptom monitoring. The overall goals of rehabilitation are to restore their functional capacity, reduce cardiovascular risk factors, improve confidence with activity, and safely transition the patient back to independent living. So, phase 1 cardiac rehabilitation occurs during hospitalization and typically lasts between 2 and 5 days after surgery. The primary goals are preventing complications associated with bed rest, promoting safe mobility, improving circulation, reducing pulmonary complications, and educating the patient about recovery. Research consistently shows that early mobilization reduces deconditioning, improves functional outcomes, and shortens hospital length of stay. At this stage, exercise is focused more on mobility and physiologic recovery than on improving fitness. A typical phase 1 exercise prescription would include multiple short activity sessions throughout the day. Type of exercise would include seated exercise, standing activities, hallway walking, transfer training, and stair assessment before discharge, if appropriate. The frequency would be 2 to 4 sessions daily, allowing enough rest throughout the weeks. And the intensity would also remain very light, generally between 9 and 11 on the Borg RPE scale. So realistically, this will not cause the patient any harm throughout this process. The duration would begin 5 to 10 minutes and gradually increase towards 15 minutes as tolerated. The physiologic rationale about this plan is that short bouts minimize cardiovascular strain, but it is still stimulating circulation and maintaining skeletal muscle function. A sample progression might begin with sitting at the bedside and standing on post-operative day 2, followed by hallway ambulation later that day, and longer walking distances over subsequent days. This gradual progression allows physiologic adaptation without overwhelming the healing cardiovascular system. Monitoring is critical during inpatient rehabilitation as the heart rate, blood pressure, oxygen saturation, symptoms, and RPEs should be asserted before, during, and after activity. Exercise should stop immediately if the patient experiences severe chest discomfort, dizziness, significant shortness of breath, abnormal blood pressure responses, arrhythmias, or oxygen saturation below prescribed limits. Pain management is also important since this can alter breathing patterns, increase sympathetic nervous system activation, and reduce the willingness to move. When pain is not adequately controlled, patients often avoid activity, which can worsen deconditioning the longer that this is achieved. So sternal precautions must be followed, which should be by avoiding pushing, pulling, or lifting more than recommended by the surgical team. Patient education should focus on activity pacing, breathing strategies, recognizing warning signs, medication adherence, and understanding the benefits of gradual movement despite anxiety. The phase 2 cardiac rehabilitation begins after hospital discharge and generally lasts between 2 and 12 weeks. This phase introduces structured exercise training while continuing education and risk factor management. The primary goals are improving aerobic capacity, increasing muscular endurance, restoring physical function, and reducing future cardiovascular risk. Because exercise intensity increases during this phase, physiologic monitoring remains essential. For aerobic exercise, I would prescribe treadmill walking, cycling, and recumbent stepping. The frequency here would be 3 to 5 days per week. The intensity would primarily be guided by an RPE between 11 and 14 because of the beta blocker therapy limiting the heart rate usefulness. The duration would begin around 20 minutes and progress towards 45 minutes, depending on how the patient is able to handle this stress. The reason aerobic training is emphasized is because it improves endothelial function, stroke volume, peripheral oxygen extraction, and overall cardiovascular efficiency. Expected responses include gradual increases in heart rate and systolic blood pressure during exercise, followed by recovery towards baseline afterward. Monitoring these responses also helps determine whether exercise intensity is appropriate, and if it is too intense or not intense enough, this plan can also be altered based on the patient's reactions towards the plan. Resistance training is typically introduced once surgical healing has progressed adequately, as exercises would include seated leg press, resistance bands, wall push-ups, seated rows, and body weight sit to stands. Frequency would be 2 to 3 non-consecutive days per week. The intensity would begin around 30 to 40% of one repetition maximum and gradually increase depending on how the patient is performing. Patients recovering from CABG often experience substantial losses in muscle mass and strength, which is why this is very important to make sure that the patient stays very consistent and on par with the plan stated. Resistance training helps restore functional abilities needed for everyday activities such as climbing stairs, carrying groceries, and rising from a chair. Progression would only occur when symptoms remain stable and recovery responses remain appropriate. Progression should occur gradually, and typically this duration is increased before intensity, although there are some exceptions depending on the workout and how the patient actually responds. More oftentimes than not, you will see duration increase before intensity. The signs supporting progression include stable symptoms throughout workouts, appropriate blood pressure responses, improving the exercise tolerance, and recovery within the expected timeframes in itself. Regression may be needed if excessive fatigue, worsening angina, abnormal blood pressure responses, arrhythmias, dizziness, or prolonged recovery occur. These decisions are guided by physiologic responses rather than arbitrary timelines, meaning this is all up to the patient's reaction, and you can never skip a deadline as long as the patient is not ready for it. Phase 3 focuses on long-term independence and maintenance. At this stage, patients transition from supervised rehabilitation towards lifelong physical activity. The goal is no longer simply recovery from the surgery, but rather long-term cardiovascular disease management to where this patient can apply it to themselves. The whole point of this program. A sample phase 3 program would include aerobic exercise 5 to 6 days per week. This would be including walking, cycling, swimming, or recreational activities, which would be all appropriate for this prescription. Intensity would generally range from moderate to somewhat hard, corresponding to an RPE of approximately 12 to 15. We still want the patient to be pushing themselves and be getting better, but at the same time, not overexerting themselves to the point of overexhaustion, regression, or anything negative where the patient is not wanting to continue this further. Resistance training should continue 2 to 3 times per week. This is a given for any patient, let alone anyone working out. 2 to 3 times per week is the bare minimum that we will be looking for. Flexibility and balance exercises should also be incorporated here, as the physiologic purpose is maintaining improvements achieved during earlier phases while continuing to reduce cardiovascular risk. At the end of the day, long-term success depends on adherence. Patients should be taught self-monitoring skills during heart rate assessment, symptom awareness, blood pressure monitoring when appropriate, and the use of an RPE scale. If the patient is not understanding of any of these assessments or any of these factors when it comes into self-monitoring and adherence to the plan, it makes it very easy for the patient to kind of just push this to the side and not have that extra drive to actually want and pursue getting better. Makes it very hard for the patient to actually know what point they are at and what they need to be looking for if they are not understanding the scale that they need to be measuring. So this will be a very, very, very important part of this process. Goal setting, exercise logs, wearable technology, and social support can improve adherence, although it is very difficult for these patients to get them themselves. More inpatients than outpatients are able to receive this because they are not in the office doing this. So this is obviously a setback that we had to research and try to find through. But there are some other adjustments like knowing the assessments, the awarenesses, and understanding the RPE scale. Patients should also understand how exercise affects long-term cardiovascular health and why consistency is more important than occasional high-intensity efforts. Nothing will ever beat having the same endurance and the same durability day after day than just pushing it to the side and doing it a couple of days from now. So for my special population, I did select chronic heart failure, as heart failure patients often have reduced cardiac output, impaired exercise tolerance, and significant fatigue. Basically, it is finding the patients that are struggling the most with consistency, and we're trying to find a better solution and a better way to keep consistency with these patients. Because the heart cannot adequately increase blood flow during activity, these patients rely more heavily on peripheral adaptations from exercise training. Exercise prescriptions typically begin at lower intensities and progress more conservatively. Monitoring excessive fatigue, worsening dyspnea, edema, and abnormal weight gain becomes especially important. If the patient is not able to absolutely read and monitor their own self-worth and their own levels when they are working out, it is going to be very hard for not even just a professional, but anyone around this patient, day-to-day activities, to be able to tell if they are putting full effort, or if they are truly getting better during this exercise. It's very important for the patient to have that understanding and to be honest with how they are feeling throughout this. The evidence consistently demonstrates that appropriately prescribed exercise improves functional capacity, quality of life, and hospitalization rates in heart failure populations, mainly due to the fact of a correct exercise prescription prescribed and an efficient one where the patient is enjoying doing it rather than dreading having to do it. So across all rehabilitation phases, clinicians must recognize abnormal cardiovascular responses. These examples can include, not limiting to, new or worsening angina, significant arrhythmias, excessive blood pressure during exercise, severe dyspnea, and dizziness or syncope. So when these responses occur, exercise intensity should be reduced or terminated depending on severity. Never push back any of these examples or any of these side effects when you are working out. If this were to occur, this could lead down a terrible path that you are not able to actually get back from because of the conditioning getting worse. It's not something that you can push aside. If you feel any of these, you need to stop this. And this is a very key point that needs to be made anytime you are prescribing exercise prescriptions like this. So safety decisions should always prioritize patient stability while minimizing unnecessary activity restrictions. Consider a situation where Adam reports chest discomfort during treadmill walking while demonstrating increasing RPE and abnormal blood pressure responses. The first step that should be taken would be immediate exercise cessation, meaning stop the exercise. Vital signs would be reassessed and symptoms monitored closely, as any physician would do. You need to make sure that the patient is doing good. And because of these findings could indicate myocardial ischemia, exercise would not resume until medical evaluation confirms safety. Always put the patient's safety above anything else. So in contrast, if Adam simply demonstrates mild fatigue but normal physiologic responses, the exercise may continue with minor workload adjustments. Modifications is really all we're looking for here. Make modifications wherever you can while you're still pushing yourself so then you are still able to increase your goal and reach the high standard, which is self-discipline and self-evaluation, everything above the sun. This example does show how the exercise decisions are driven by patient responses rather than fixed protocols. Successful cardiac rehabilitation requires individualized prescription of exercise across all phases of recovery. For this patient, phase 1 emphasizes safe mobilization and education. Phase 2 focuses on structured exercise progression and risk reduction. And phase 3 promotes long-term independence and cardiovascular health. Careful monitoring, evidence-based progression, patient education, and clinical reasoning remains essential throughout the rehabilitation process and for the patient's future. Combining these principles, these clinicians can safely improve functional capacity, reduce cardiovascular risk, and help patients return to meaningful daily activities with confidence, independence, and excitement by doing these workouts. Thank you for your time.